YouTube, it's me, Rafael again. This is my next video, and I know it's been a while since I posted a video, basically mostly because of time issues, of course. I'll try to upload a little bit more frequently, but still, if you like it, subscribe to the channel and you'll be able to get more content in the future. So today's video will be about a case I recently did, and I think in showing this in a small presentation, it's easier to explain to you the reasoning behind some of the things I did. I'm just going to talk freely and basically mostly unedited, so there will be some uhs, some pauses, sometimes it will be a little bit difficult with the words, but hey, I just want to get the content out, and I don't worry too much about editing. Also, I don't worry too much about how I look. As you can see, I still have my corona coupe. I haven't been able to get to the hairdresser. Luckily next week I can go. So anyway, let's talk about this case I recently did. So as you can see, this patient presented herself with some issues. So the biggest issue was tooth 2-1, and she was having some symptoms on this tooth. It's not the only issue she has, obviously. You can see that oral hygiene is very poor and that the bridge is, well, let's say, not the best anymore. Now, the bridge has been in the mouth since the 70s, so basically, what is it, 40, 50 years almost, that's it, that the bridge has been inside. So you could say that it's more or less a success up until now. There's another problem here. As you can see, the gingiva, especially around the central incisor and the canine, is severely inflamed. You have some pockets there. So basically some periodontic issues also, and a lot of tartar, staining. Well, anyway, the problem now was that tooth 2-1 was symptomatic, and it previously had another apical resection. So this is the picture that the dentist sent to me, and as you can see, we have some issues here. So there's an old apical surgery that has been performed, typical oral surgeon apical surgery. So it's filled with amalgam. That's the first problem. Now, amalgam is not biocompatible, it leaks, it's not the best retrofill you can place. Another problem is that there has been no previous root canal treatments. This sometimes boggles my mind. How can you expect the apical surgery to be successful if there's not even been a root canal treatment? So it's not the right way to do things. I don't know when it happened, but still the normal procedure would be just do a root canal treatment through the crown, and probably that would have solved the issue. Also, this gives a bad reputation, as we all know, to apical surgery. So if you look at apical surgery in the traditional way, as it was performed here, it has a success rate of about 50%, which is not good. And if you do apical surgery according to modern protocols and microsurgical, well, then the success rate goes up into the 90%. So the problem here was poor apical surgery, and she had some infection there. So I decided, let's do first a root canal treatment to the crown, and I would do a procedure that we call pack and whack. So first I do the root canal treatment. I fill the canal with some biocompatible material. In this case, because I'm going to combine both the non-surgical root canal treatment and the surgical root canal treatment in one visit, I was not opting for MTA. Normally I would do, in a pack and whack procedure, I would use MTA, but in this case the MTA will not be set. It has a higher chance chance of washing out, so I decided to go with biodentin. Biodentin, after a few minutes, it's already set enough so it doesn't wash out when we do the resection. So this was the thing I was going to do. First of all, I did the root canal treatment, so it starts with the basics. You first isolate with rubber dam, of course. It's a little bit more difficult than normal when you isolate with a bridge, but still, it's perfectly possible. What I do use when I isolate in these cases, I use Orasil, as you can see on the picture there. I also made just a small opening, which was sufficient, and then we did the normal procedure of cleaning and shaping, so sodium hypochlorite, citric acid, some ultrasonic activation, and eventually we filled the canal. Now the next picture is also a little bit interesting. So you can see a cotton pellet in the opening cavity. Why do I use the cotton pellet? Well, basically this is after I fill the root with biodentin. So if you're going to fill the root with biodentin and after this I still need to edge with porcelain edge and use some monobond and stuff, if you just leave the biodentin not covered with a cotton pellet or something, there's a bigger chance of washing it out again. So I place a cotton pellet on top of the biodentin, then I'll do my etching and everything, and after this I can remove the cotton pellet, and as you can see in the final picture here, biodentin is still in place, it looks nice, and we can proceed with the bonding procedure. Eventually, after the root canal treatment, which took about, I think, 30 to 40 minutes, it looks like this. So you can see the biodentin on top of the amalgam retrofill. Biodentin is not that opaque, which is something I do not like that much, but hey, doesn't matter. And yeah, the final restoration, it looks a little bit grayish, even though I used a masking liner, but still the core was completely in metal, and everything of tooth structure was completely discolored. So it still looks a little bit grayish, but yeah, we all know it's on the palatal side, so it doesn't matter that much. So this was the first step of the treatment. After this, for me, it was pretty simple. We anesthetized the tooth. So I did this first part of the treatment without any anesthesia. And then I put in the anesthesia. Why didn't I do it in the beginning, anesthesia? Well, because of the hemostatic effect. So you get, if you put in anesthesia, and you wait too long, then you get what we call the rebound effect, and everything starts to bleed, and basically it's not controllable anymore. So the first part in this case was easy, no anesthesia, just do the root canal treatment, and then afterwards I placed the local anesthetic, and meanwhile we put the patient in the waiting room. She could get to her senses a little bit, and we put everything sterile for the surgical part. So this is a picture of the surgical part. As you can see, I opted for an Oxenbeim-Lübke flap design. Normally I would just do a simple circular incision, a triangular flap, but because, you know, the periodontal issues, it was heavily inflamed, I do not want to cut in inflamed tissue that much. And you'll see at the end result that even then it was not perfect. So anyway, we did an Oxenbeim-Lübke flap design, opened it up, made a window, and we resected the tooth. Then what we saw was this picture. So you can see the biodentin there clearly, but still I needed to resect a little bit more, because this is one of the advantages of microsurgery. You can still see this little piece of amalgam there, so it's not completely resected up until the part where we wanted to. Next picture shows, this is a little bit, I just shaved it off a little bit, and then we don't have amalgam anymore. Everything is resected, everything is clean, everything was checked. And so the only thing to do now, after we of course checked it with a radiograph, was to suture everything back on. And this is for now the temporary result. As you can see, suturing suturing was a bit of a problem here, especially if you look at the canine. We have some recession there. The gum at the central incisor, it's probably going to give some recession too. Let's hope not, but we'll see. The problem here, of course, was the previous apical surgery left a lot of scar tissue because they used the semilunar incision, which makes it much more difficult to retract it perfectly. Also, there was not much attached gingiva, so basically even at this level I was cutting in mucosa. But still, we'll see how it ends. The human body sometimes amazes me, and I'm pretty sure that in 2 weeks when I see her back, just for the control, that everything will be healed. But the recession on the canine probably is inevitable. Next step after this, of course, if everything is healed, would be to do a new bridge. But before that, I think we should do a thorough cleaning of the teeth first, restore some of the old restorations, do some analysis of the occlusion and everything before we will make a new bridge. Well, I'm not going to make a new bridge because I'm an endodontist, but this is something I will strongly advise towards the patient and towards the dentist. Well, instead of showing you perfect pictures before and after, I think that a case like this shows you what everyday dentistry is like, and even though it's not perfect, in the end I think the case will heal, and maybe you learned something from it. So if you found this interesting, again, subscribe to the channel, keep an eye on my Facebook page, and see you soon.